Okay, so we're going to continue with chapter 20, talking about the heart. I'm going to go over this. I printed this out for you today, so you have it. I just want to go over a couple of things. This kind of explains the ECG then that we just went over. And then we're going to move on and look at the conduction or the contraction cycle, okay, the actual cardiac cycle. Okay, are we all set?
I'm good. I'll just...
Okay. All right. All right. So this is just showing the conduction system. So you can see on here we have that SA node, and we have the AV node, and we have the AV bundle, and the bundle branches, and then the Purkinje fibers. So we want to identify all of those places. And so when you see just before that sinus rhythm starts, so this is the sinus rhythm, right before that starts, you see a line leading up to that. The SA node just starts to become stimulated through, it has a spontaneous depolarization. I'm going to show you those action potentials in just a minute. And so then the SA node starts to beat at about 60 to 100 action potentials per minute. Now we know that the parasympathetic nervous system is overriding, it's got a solid background noise pretty much that it's sending parasympathetic innervation to that SA node. So the action potentials will actually not be as high as 100, and the average is around 72 action potentials per minute or 72 beats per minute, right, at rest. So that's what the SA node is putting out, about 72 action potentials per minute, which lead then to 72 beats per minute, right? So we have the SA node that gets stimulated, and that's right before we see the P wave. Then the next thing that happens is that we see that the electrical impulses start to spread throughout the atria, through that internodal pathway, right? And so we can see the pink area in here that I have, that's where the atria is starting to become excited. The contractile cells are starting to get excited. And so now we see that P wave occur because the P wave signifies atrial depolarization. So all of those cells are depolarizing, they're getting ready to contract. They're becoming excitable, right? And then what happens is that that signal, that stimulation gets down to the AV node, and as it gets to the AV node, there's a 100 millisecond delay at that AV node, and that allows both of the atria then to contract before the ventricles get that stimulation, because we want the atria to contract before the ventricles. So now we see, here's our 100 millisecond delay after that P wave, right? Okay, then the next thing that we see is that the stimulation then, those action potentials, are going to leave the AV node. They're going to leave at the same pace that the SA node had set up, right? The 72 action potentials per minute. If that SA node wasn't working, the AV node would then become the pacemaker cell and then would be putting out about 40 action potentials per minute. But as long as the SA node is working, it's just going to continue putting out the same amount of action potentials that the SA node did, okay? So it starts to spread those action potentials down through that AV bundle, then down through those bundle branches, and they go down through that interventricular septum. Right? So as that is being spread down that interventricular septum, we see that QRS complex starting, right? Then what happens is we get here, and we see that the stimulation then has spread around those Purkinje fibers. And now the Purkinje fibers are giving that stimulation to all the contractile cells in those ventricles. And so here you see the QRS, the rest of the QRS complex, occurring as those ventricles are receiving that stimulation, so they're depolarizing, and very shortly then after that, the ventricles contract, right? And then the last thing that's going to happen is that the ventricles After the contraction of the ventricles, which would occur here, then those ventricles are going to repolarize and relax. And that's what we see in that T wave. Right? So that's the whole sinus rhythm. So when you're looking at, problems with the P wave, you're looking at the atria. Is the atria depolarizing? Is the, how you're looking, at those different things that we had talked about last time. When you're looking at the QRS wave, you're looking at the ventricles. Are the ventricles depolarizing and contracting normally? And then when you're looking at the T wave, you're looking to see, are the ventricles repolarizing? Are they resting? Are they having a chance to rest? Or is the ventricular contraction so strong and so fast that it doesn't have a chance to rest? Right? So I also wanted to show you here the actual action potentials. So this is the SA node, and I keep talking about. Okay, so the SA node, this is what the action potential sort of looks like. It has a spontaneous depolarization where those sodium, usually we have to have a stimulus, right? Usually there's a stimulus that will open up that sodium, those sodium gates, and sodium will rush in to get to threshold. Well, not so with the SA node. The SA node is a pacemaker cell that's going to depolarize all on its own. It doesn't require a nerve sending it a message to get it to depolarize. So the sodium gates are open, and it doesn't stay at resting, and the transmembrane potential is going to, all on its own, reach threshold. As soon as it reaches threshold, then all those voltage-gated sodium channels open up. We get depolarization. Then the sodium channels close, and the potassium channels open, and we get repolarization. And then we go back down to resting again after that. So it's just a little bit different. The other thing that you're going to see that's a little bit different is that the threshold number is different. When we were talking about neurons, right, we said that resting was 70, threshold or negative 70, and threshold was negative 60. I'm not going to ask you about the charges there, but you can see that it's not the same as what we were talking about in the neurons. As a matter of fact, let me just show you this down here, because this is what we were talking about with the neurons. If you remember, we had so go here. Here's resting, and then there's a stimulus like the chemicals, there's ACH that binds, and then the chemical gated channels open up, sodium starts to come in, we get that graded potential. Then it hits threshold, then the voltage gated channels open up, and then sodium rushes in and we get depolarization. Then the sodium channels close and the potassium channels open and we get repolarization. Then the potassium channels start to close and we get hyperpolarization, then they're all closed and then we go back to normal, right? So we're getting the same things occurring with the SA node. The big difference though is that we don't need this. We don't need that stimulus. It just depolarizes all on its own. That's what makes it a pacemaker cell. And the AV node also has that same ability to do that. Okay. So the next thing we want to talk about, though, we're done talking about the conducting system. Now we want to actually talk about the cardiac cycle. We want to talk about the contractile cells, those cells that are actually going to contract and cause the atria to contract and the ventricles to squeeze, cause them to both squeeze. Now those cells are going to look a little bit different as well. So here's the action potential. When those contractile cells receive that stimulus, this is what's going to happen to the contractile cells, right? So let's take a look. They receive a stimulus. So this is the first thing they're going to do. They're going to get a stimulus. And where are they getting that stimulus? They're getting it from the SA node, right? And that's being transferred down that conducting pathway. So those contractile cells are going to get that stimulus there. All right, then the sodium-gated channels are going to open up and sodium enters. So sodium comes into the cell and we move from a negative 90, which is resting in the contractile cells, and we depolarize all the way up to a positive 30. So all of that is called depolarization. So that's the first step that occurs in a contractile cell, right? When we are stimulating a contractile cell. Then, and this all sounds similar, doesn't it? Then we reach positive 30 and the sodium gated channels open, and at the same time that the sodium channels open, we get calcium channels that are going to open and potassium channels that are going to open, right? So two things now. It's a little bit different. We have calcium and we have potassium. So when we were looking at a cell, so here's like a muscle cell here, right? Potassium's higher on the inside of the cell. Calcium's higher on the outside of the cell. So our sodium channels have closed, the calcium channels have opened, and the potassium channels have opened. Potassium's going to want to move in. It's going to go down its concentration gradient. Potassium wants to move out. It's going to go down its concentration gradient, all right? So we look at this and we see, okay, here we have just a little bit of a dip because the potassium channels open up first, and so potassium starts to leave the cell, and the cell becomes more negative as that positive charge is leaving, okay? But then we see that it flattens out, and when it flattens out, that's because the calcium channel's open. So now we have positive charges coming in and positive charges going out, and they both cancel each other out. So we end up with this straight line here then. That is called the plateau. That is the second step in the action potential of a contractile cell. Okay? We get a plateau because calcium's going into the cell, potassium's going out of the cell. They're both positive charges. They're canceling each other out. So on this graph, we're not going to see anything but a straight line. But then eventually, those calcium channels are going to close, right? Almost around, just before 200 milliseconds. The calcium channels close. Well, now it's all about the potassium. So potassium leaves, and the charge inside the cell then starts to become more negative because now it's just calcium that we're talking about, just potassium that we're talking about. So now we get our normal repolarization. Okay. The repolarization is going to continue until it gets down to its resting membrane potential. It's going to stay at the resting membrane potential then until it receives another stimulus. So this is something that we see in the heart contractile muscles. We don't see this in our skeletal muscles. We don't see this in our neurons. This is our contractile cell of our heart. So why would we actually want that to occur? Well, part of it, mostly it's because when calcium is involved and you get that long plateau, that is the absolute refractory period where no other action potential can occur on that cell in that time. Okay? That's an absolute refractory period. Remember, we said that the only way that you could have another action potential occurring is if it were in the refractory period or when it was at the relative refractory period or when it was at rest. When we're talking about neurons, right? So what we have is that when the sodium channels regain their normal resting status, that's the only time that another action potential can really occur. So we have the relative refractory period from the time the sodium regains its resting status until the time it gets back to just a resting membrane potential. That's a relative refractory period where you could get another action potential, possibly. So why does this matter? It's so that when the cell contracts, you're not going to get another contraction too close to the previous contraction. You have this long waiting period where this absolute refractory period is. You cannot get another contraction. You can't get another action potential. That means that if action potentials come too close together, it's tetany. And your heart should never go into tetany. That would spasm up, and then it wouldn't be beating. You wouldn't be able to push the blood out of the heart. So it's that calcium that is going to prevent tetany, right? Okay. So this calcium then that we see here actually comes from two different places. Okay, so first of all, calcium. It's a big deal with the heart. The calcium is going to come, 20% of it comes from the extracellular fluid, right? Those calcium gates open up. On the contractile cells, calcium comes into the cell from the extracellular fluid, and that starts the plateau, right? 20% is going to come from the extracellular fluid. But the other 80% then, this calcium from the extracellular fluid is going to trigger calcium to be released from the sarcoplasmic reticulum. If you remember what the sarcoplasmic reticulum is, it's one of the organelles inside contractile cells that store calcium. So this 20% from the extracellular fluid is going to trigger this 80% from the sarcoplasmic reticulum to be released, and that gives us enough calcium for that entire plateau. Okay. Okay, in addition to calcium, we also need ATP in order for those contractile cells to contract. And we know to make ATP, we need glucose or some other nutrient, and we also need oxygen. The great thing about these contractile cells is that they can store oxygen. So even at capacity, the oxygen reserves that those cells have is sufficient to produce enough ATP in order for that heart to beat, even at maximum, at full capacity. All right, so now we're going to look at what's called the cardiac cycle. And the cardiac cycle is the start of one heartbeat to the start of the next one. Does everyone have this printout? Anyone need the printout? Okay. Okay, so when we're looking at the contraction cycle or the cardiac cycle, we need to remember that systole is when we're getting contractions, and diastole is when we're getting relaxation. So you probably remember that from general A&P, right? Systole is contraction, diastole is relaxation. So we need to keep that in mind. We're going to talk about the different steps, the different phases that the heart goes through in one cardiac cycle. We're going to look at the valves. That's going to be really important for us to see, are the valves open, are they closed? We're going to look at pressure and which way is the blood going, where are the pressures, all right? So let's take a look at the start. So this is where we're going to start right here. We have the SA node that reaches threshold, and we get that P wave, right? And as soon as we get the P wave, shortly after, we're going to have atrial systole. So that name tells you that the atria are contracting. That's what that means. Atria are contracting, atrial systole. All right? Now, just before this happens, because this is when that cardiac cycle is starting, but just before that, we have blood that's just passively moving into, I'm going to do, what do I want to do? It's passively flowing in through the superior and inferior vena cava, down into that right ventricle, and it's flowing into the right atrium, or I'm sorry, the left atrium, down into the left ventricle. So blood is just passively filling up the ventricle. And before we even start this cardiac cycle, the ventricle is about 70% full on both sides, right? So from now on, I don't want to keep going back and forth between the colors. I'm just going to go with the left ventricle. We'll see. But it's just passively filling, and it's going to fill up to about 70% of its capacity. And that's where we actually start. That's when the SA node becomes stimulated, we get that P wave, and then we're going to get the atrial contraction. So when the atria contracts, I should tell you that as the ventricles are filling up, those valves, the AV valves, they're going to be open. They have to be open, right? So the AV valves are right here. This is the tricuspid valve, and right here, this is the bicuspid or mitral valve. So they have to be open in order for those ventricles to fill with blood. All right, and then we get the atrial contraction. That's the first step that occurs. The atria contract, and when the atria contract, they're going to add the final 30%. It was already 70% full, but now we're going to get it to 100% of however full it's going to be. And that's when the atria contract. It adds that final 30%. At this time, you'll see that the those other valves called the semilunar valves, we have both the pulmonary semilunar valve here and the aortic semilunar valve there. Well, those valves are closed. There's not enough pressure at this point to open those valves, so they're just closed. So we just have the AV valves opening, and now the ventricles get completely filled, right? So that is atrial systole when they contract, and now the atria are going to go into relaxation, so they're going to go into atrial diastole until the next cycle starts. So on this picture then, this is going to be the next picture that we see. On the ECG, we're going to see the QRS complex, because we know the next thing that's going to happen after the atria contract is the ventricles are going to contract. So we'll first see the QRS complex, and then we're going to see how the ventricles contract, right? So the next phase we say is atrial systole, first of all. That's just going to happen. The atria have to contract before the ventricles contract, right? We have to have the atria relaxed. You can't have them both contracting at the same time. That would be futile. So the atria are relaxing, and now the ventricles are going to start to contract. Okay? So the ventricles begin to contract, and as they're squeezing in and contracting, they're squeezing in, there's enough pressure there to close those AV valves. So those AV valves then are closed. The semilunar valves are still closed as well. There's not enough pressure yet to open those up. So at this point, all the valves are closed. But there's pressure going on in there. There's all this pressure, but blood's not going anywhere. So we call this phase, it's the first phase of ventricular systole, we call that isovolumetric contraction. And the reason we call it that, iso means the same, volumetric means volume, it's the same volume. The ventricle is contracting, but the volume inside the ventricle isn't changing at all because all the valves are closed. So that happens in the first part of ventricular systole. We get that isovolumetric contraction. Volume stays the same, all valves are closed, blood's not going anywhere, but the ventricles are contracting. Then the second stage of ventricular systole, and again, we still have the atria are relaxed. The atria are going to remain relaxed until the next cardiac cycle starts. In this second stage of ventricular systole, there's so much tension in the ventricle that it finally pushes open those semilunar valves. So the semilunar valves open up, and blood is going to eject from the ventricles into the pulmonary artery, the pulmonary trunk, and into the aorta. So blood gets pushed into those two ventricles, and now blood is leaving. So in this phase, in this second phase of ventricular systole, the semilunar valves open and blood ejects. All right? We're going to look at what we call stroke volume. We're going to look at that a little more closely in just a few minutes. But the stroke volume is the amount of blood that is ejected from that ventricle. How much blood is ejected from the ventricle? And there's another term that's called ejection fraction, and that's the percent of what was ejected. So we started out with this much, now we only have, and this much went out. What is the percent of what was ejected? What's the percent? Okay, so we're going to look at those two things in just a little bit. But this is the end then of ventricular systole. The next thing that we have here is where both of them are going to relax. Both the atria and the ventricles are going to relax. So we start ventricular diastole. We are still in atrial diastole, right? On the ECG, you'd see the T wave first, and then the ventricles would start to relax. The T wave is just telling you that those potassium channels are open, potassium's leaving the cell, we start to repolarize. Okay. And in the first phase of this ventricular diastole, there's two phases of ventricular diastole. The ventricles are relaxing, right? And as they're relaxing, we have the blood up in the pulmonary trunk and the blood in the aorta. The pressure in there starts to build up, and it closes those semilunar valves. So both of those valves are closing because there's a pressure as the blood leaves and goes up into those big vessels. They're going to, and the ventricle starts to relax and nothing's pushing it forward anymore. That blood's going to kind of come back towards that valve, and as it comes back towards that valve, it's going to close those valves. And so the ventricle is relaxing, all the valves are closed. There's not enough pressure to open up. There's not enough pressure in the atria to open up the AV valves. So those AV valves remain closed in this phase. So now all the valves are closed again. And so all the valves are closed and the ventricle is relaxing. So we call this isovolumetric relaxation, because the ventricles are relaxing, but the volume of blood in the ventricles is not changing in this first phase of ventricular diastole. So we call it isovolumetric, same volume, relaxation, because the ventricles are relaxed. Okay. Then we get into the last phase of ventricular diastole. And this is when the ventricles are so relaxed that the pressure in the atria is exceeding the pressure in the ventricles, and it forces those AV valves to open up. So the tricuspid valves and the bicuspid valves now open up because there's enough pressure here in the atria to push them open. It pushes them open, and those AV valves open up, And now we're kind of back to where we started, and we have this passive filling of blood. We've got blood coming in through the superior vena cava and in through the inferior vena cava and going down into the right ventricle. And we have blood coming in through the pulmonary veins into the left atrium, and then that blood is going through those open mitral valve, that open mitral valve, and filling up the ventricle. So we have this passive filling. Atria aren't contracting, everything's at rest, everything's relaxing, and blood is just flowing passively into the ventricles. And that's where we started. Now we go back here and we start, and the ventricles get filled up about 70% of the way, and then the atria are going to contract again, and that's atrial systole, and it's just going to keep going around and around and around, right? Now the atria are always going to, both atria are going to contract at the same time, and both ventricles are going to contract at the same time, but the blood movement is going to be in a circuit. So, and I know you know that, but the blood goes into the right side of the heart and then to the lungs, and then it comes back to the heart on the left side, and then it goes out to the rest of the body. So we have this circuit of blood flow, but we have the atria contracting at the same time as the ventricles. Okay, so that's the cardiac cycle. Now, another thing that I'd like you to know is the heart sounds. So back here, when we were looking at when the atria have already contracted and now they're relaxing. Okay, the atria have contracted, now they're relaxing, and then the ventricles start to contract in that first phase of ventricular contraction that we call isovolumetric contraction, and those AV valves slam shut. That's what gives you that first heart sound. And that first heart sound is lub. So the heart sound is usually, it's a lubbed up, right? So the first heart sound is when those AV valves are closing, and we call that S1 or lub, when the AV valves close. And that happens in that first phase of ventricular systole. Then if we look at the first phase of ventricular diastole, we have enough pressure here that closes those semilunar valves. And when those semilunar valves close, that's the DUP sound, and that's S2. So DUP is S2, okay? There's a couple of other heart sounds that we hear as blood is moving through the valves. We have S3 and S4. They're not as well heard, and so we're gonna kind of stick with the lubbed up. Okay. Those are very well heard. Okay, so now we're going to look at a little bit of physiology, and we're going to look at cardiac output. Cardiac output tells us how well the heart is working. Cardiac output is the heart rate times the stroke volume. So the heart rate, or CO, cardiac output, equals heart rate times stroke volume. Okay? So the heart rate is the number of heartbeats per minute, which on average for, is somewhere around 72. That's about normal. 72 heartbeats per minute. At rest, right? With exertion, it's going to go up. Stroke volume, like I said earlier, is the amount of blood pumped out of a ventricle each contraction. So what is the volume of blood that is pumped out of a ventricle at each contraction? So if we look at the values, cardiac output is in mils per minute. How many milliliters per minute is the heart putting out? how many milliliters of blood is the heart putting out every minute. So it's the heart rate, which is beats per minute, times the stroke volume, which is milliliters per beat, and that's how you come up with cardiac output. So you're going to need to memorize this, not hard, but cardiac output, for an example, on average, if you had a person that had a 75 beats per minute, that was their heart rate, 75 beats per minute, and their stroke volume was 80 milliliters every beat, you would multiply those two things together, so our cardiac output would be 6,000 milliliters per minute. Well, that's kind of, let's not use milliliters, let's convert it to liters. That means 6 liters per minute, and that's an average, that's normal. That's a normal cardiac output. Okay. Heart rate, we're going to talk about heart rate and things that influence heart rate, and we're going to talk about things that influence stroke volume. So first I'm just going to go through the wording and explain it, and then we're going to look at a picture so that you can see what each one of these things is.
Do you have extra copies of that?
Stroke volume is the most important factor when examining a single cardiac cycle. Just one cardiac cycle, from atrial systole all the way back to the beginning of the next atrial systole. So when we are looking at stroke volume, we want to be able to measure how much blood is ejected from that ventricle. Now, it's kind of hard to measure the amount of blood that's being forced into the aorta, right? I mean, how would you actually be able to measure that? It wouldn't be very easy to measure how much blood is moving out, right? So what we have to do is we have to look at, well, how much blood is in the ventricle? How much blood is in there before it contracts? And then how much blood is in there after it contracts? And if we subtract those two numbers, now we can see how much blood was actually pushed out. Okay? We'll go over this in a picture so that you see this. So the amount of blood that's in the ventricle before it contracts is called the end diastolic volume. So that's how much blood you start out with in the ventricle. Then the ventricle contracts, and whatever is left in there at the end of the contraction, that is called the end systolic volume. So if we subtract what you have left from what you started out with, now you can see how much actually went out. Because it's pretty hard to put a probe in that aorta and measure how much blood came out. We'd have to measure what's in a container. We can measure blood in a container like the ventricle. So that's why we are measuring the end diastolic volume and the end systolic volume, because they're measurable, right? So the end diastolic volume is the amount of blood in the ventricle at the end of ventricular diastole, when it's done completely filling, right before it's going to contract. And the end systolic volume is the amount of blood in the ventricle when it's done contracting, at the end of ventricular systole, right? So that's the stroke volume, and then the ejection fraction is the percent of the end diastolic volume that's ejected. So then we'd have to divide those two. Instead of subtracting them, you would divide to see what the percent of end diastolic volume is. So we're going to look at a couple of examples here so we can see. So let's take a look at this picture here. Okay, so the ventricles are relaxed and they're filling up with blood. First we get the passive filling, and the passive filling gives us 70%. And then the atria contract, and the atria give us another 30%. And now we're as full of blood as we can possibly be. We're as full as we're going to be before the ventricles contract. right? So you guys all get that, right? It's passive filling, and then the atria contract to push an extra 30% in. Now we've got 100% of what we're going to have. So at the end of the ventricles relaxing, we have 100% of the blood that we're going to have that can be, ejected. 100%. So this is what's called the end diastolic volume. Those ventricles are full. The next step is they're going to contract and push some of that blood out. So we're measuring the container. We're measuring the amount of fluid in the container. And that's the end diastolic volume. We have that certain volume of blood, right? So then the next thing that's going to happen is that the ventricles are going to contract, right? So the ventricles contract, and as the ventricles contract, blood is moving out into the pulmonary trunk and the aorta, and that volume of blood starts to go down, right? We start to lose blood in that ventricle as those ventricles are contracting and pushing the blood out. And at the end of the ventricles contracting then, at the very end of ventricular systole, there's still a little bit of blood left in those ventricles. Just a little bit of blood left in the ventricles. That blood that's left is called the end systolic volume. The end systolic volume. It's at the end of ventricular systole. That's what we have left. So that's why we call it the end systolic volume. Okay? You see, we can't measure the blood that's been pushed out into the pulmonary trunk. It's going too fast. We have to just measure what's in the container. So now we've got two volume levels. We have the end diastolic volume, and then we have the end systolic volume. And we can find the stroke volume from there. So the stroke volume then is the end diastolic volume minus the end systolic volume. Okay? So if we looked at normals, if we look at an example here, here we see that the end diastolic volume is about 120 milliliters. That's how much blood is in those ventricles right before they contract, 120 mils of blood. And then after they contract, we have 50 mils left in the ventricle. So knowing those two numbers then, how much blood was actually pushed out of the ventricle? That's right, 70 milliliters was what was pushed out. That's how much blood was pushed out of those ventricles into those major blood vessels. That's stroke volume. Okay, and then we have the other value that we want to figure out, which is the ejection fraction. So to figure out the ejection fraction, we're going to take the end diastolic volume. To find the ejection fraction, you're going to take the end systolic volume and divide it by the end diastolic volume. And that will give us the percentage of the blood that has gone out. So we know end systolic volume is 50 and end diastolic volume is 120. So what would be your ejection fraction then? Does anybody have a phone out? They can do that?
41.67%.
Right, so like 42% would be the ejection fraction then, 42% in this case. You're just looking for the percentage instead of the actual volume. Now we're going to look at some factors that are affecting stroke volume, and then we're going to look at some factors that are affecting heart rate, and then that should be it. Let's hope we get done. Okay. All right. So, all right, so we're going to first look at end diastolic volume. Let's take a look at end diastolic volume. So this is blood is filling up the ventricles. So we're looking at, well, what can affect that? What can affect, maybe make that smaller than it should be, or maybe make it bigger than it, more than it should be? That's what we're looking for. So what do you think? First of all, the venous return. How much blood is coming back in those veins? That would affect end diastolic volume, don't you think? That would affect how much that ventricle filled up, how much blood is coming back in the veins. So the venous return can be affected by things like your skeletal muscles, because your skeletal muscles are supposed to squeeze those veins and push that blood back to your heart. So if a person is not, if they're very sedentary, right, they're not going to be able to bring that as much blood back. The blood volume, if they don't have, the high enough blood volume, they're dehydrated, they're hemorrhaging, right, something like that. If the blood volume isn't there, then you're not going to get enough, you're not going to get as much blood coming back and filling up those ventricles. And then also we have peripheral circulation. If something's slowing down the peripheral circulation, like atherosclerotic plaquing or something like that, and it slows it down, well, then now blood's not coming back to the heart as fast as it should. So then the filling is going to be less, right? So anything that increases the venous return is going to increase the end diastolic volume. And anything that decreases the venous return is going to decrease the end diastolic volume, right? That just makes sense. If you're not bringing it, it's not going to fill, right? All right, the second thing that can affect the end diastolic volume is called filling time. Filling time. So filling time is how long did it have to fill? Did the next atrial contraction come too fast so that the ventricles didn't have enough time to fill? Are the ventricles contracting too fast so that it doesn't have enough time to rest and fill? So we're looking at the filling time. How long is that ventricle relaxed? How long does it have to fill? So anything that increases the filling time, where the ventricles are relaxed, is going to increase the end diastolic volume. It's going to increase how much blood fills in the ventricle. Anything that decreases the filling time will decrease the end diastolic volume, right? You have to have time to fill the ventricles. Without time, you're not going to fill them as far as they should. And your end diastolic volume will go down, okay? All right, well, both of these things are going to affect what we call preload. Preload is the degree of stretch on the atria. On the ventricle. The degree of stretch on the ventricle. So the more it fills up, do you think you have more stretch or less stretch? More. So the more that ventricle fills up, the more preload you have, right? And then preload, how much blood you have in the ventricle, or in that ventricle then, is going to determine the end diastolic volume. It doesn't determine the end diastolic volume, but it's a degree of the end diastolic volume. It's the degree of stretch. So we could say, in other words, let me say it this way. If you have increased preload, that means that there's more blood in the ventricles. If you had decreased preload, that means there's less blood in the ventricles. It's probably a better way of saying it, right? So when we look at the end diastolic volume, we look at Frank Starling's principle. Frank Starling's principle says, well, the more in, the more out. the more blood you have in your ventricles, the more blood the ventricles can push out. So the greater the stroke volume is going to be, right? Does that make sense? The more blood that's in the ventricle, the more blood you have to actually push out. So we could say then, when we're trying to relate this to stroke volume, if you have more end diastolic volume, if you have a higher end diastolic volume, you're going to end up with a higher stroke volume. More in, more out. And if you have a decreased end diastolic volume, you're going to have a decreased stroke volume. Right? Less in, less out. Okay, so now let's move on and let's look at the end systolic volume. End systolic volume, okay? Let's look at the factors, some things that will affect the end systolic volume. All right, so first of all, we're going to look at two different things with the end systolic volume. Well, there's three things actually that are going to affect it. Let's go through each one of those. So first of all, we have sympathetic stimulation. Sympathetic stimulation is going to increase contractility of the ventricle, right? Sympathetic nervous system is that fight or flight, so it's going to increase the strength of the ventricle contraction. So let's look at it this way. If the ventricles contract really strongly, are you going to have a large or a small end systolic volume? Smaller, right? Because you've pushed more out, so there's less left. If you have less of less contraction, if your contractility is decreased, you're going to have a lot more left over in that ventricle, right? Okay. So sympathetic stimulation is going to increase the strength of the contraction, which means there will be less left over in the ventricle, so your end systolic volume would go down. These hormones right here, epinephrine, norepinephrine, glucagon, and thyroid hormone, well, epinephrine and norepinephrine are kind of like in the same class as they're sympathetic neurotransmitters or sympathetic nervous system chemicals. So they're going to do the same thing. They're going to increase contractility. So the stronger the ventricle contracts, the more blood gets pushed out, the less blood's left over, so your end systolic volume is decreased. Okay. Then on the opposite spectrum, we have the parasympathetic stimulation. What does parasympathetic stimulation do to contractility? It decreases it, right? So the parasympathetic nervous system decreases contractility. So now that ventricle isn't contracting as strongly. So what is your end systolic volume going to do? Is it going to be more or less? It's going to be more. There's more left over. The ventricle didn't contract strong enough to push that blood out. So there's going to be more left over in the ventricle. All right, so one thing you're going to hear about in pharm is the term ionotropic. So anything that strengthens the contractility, we say is positive ionotropic. Anything that decreases the strength of the contraction is going to be negative ionotropic. Ionotropic just means that they're talking about the depolarization. So anything that increases that depolarization is a positive ionotropic. Anything that decreases the strength of the contraction or the depolarization is negative ionotropic. So you hear about some drugs that are positive ionotropic. Okay, well, let's see. What's another thing that is affecting our end systolic volume? we have this thing here that is called afterload. Afterload is the amount of tension that's needed to force open the semilunar valves. Okay? The amount of tension that's needed to force open the semilunar valves. All right, so we have here's your aorta, right? And then here we have your semilunar valve, okay? So that valve is going to open up when the pressure of the blood in the aorta pushes against it and forces it open. So we think about some things. This is afterload, is how much tension is needed to force open that semilunar valve, right? So anything that causes anything that increases that afterload, increases the amount of pressure that's needed to open that valve, is going to increase the end systolic volume. Anything that decreases the afterload is going to decrease the end systolic volume. So if you have a vasodilation, so if there's vasodilation, not necessarily of the aorta, but of other blood vessels in your, as the aorta starts to branch, and these other blood vessels are dilated, right? Then there's not as much pressure coming back because the blood vessels are dilated and the blood can keep flowing forward, right? Does that make sense? If you have vasodilation, those peripheral blood vessels are getting bigger, and it's easier for blood to move forward. With vasodilation, blood can move forward, and then there's not going to be as much coming back and closing those or opening those valves up. So in that case of vasodilation, afterload is actually going to decrease. And if the afterload decreases, then it's going to be a lot easier for the ventricles to push the blood out, and the end systolic volume then is going to be less. There will be less left in the ventricle. You kind of get that? But if you have, say you have vasoconstriction then. If you have vasoconstriction, and so vasoconstriction can be caused by a couple of things. You know, it could be caused by, high blood pressure. It can be caused by atherosclerotic plaquing. So if you've got a lot of atherosclerotic plaquing down here and blood gets slowed down, it's going to end up backing up this way. And now it's going to be a lot harder for those ventricles to push and get that blood out, right? It's going to be harder to push the blood out of the ventricles. Make sense? Okay. All right, so hopefully I didn't say that wrong before, but when the blood pushes back, it closes those valves and not opens them. It's not opening it. Opening it is from the ventricles when the ventricles push out and open the valves. So it's like, which pressure is greater? If this pressure is greater, then it's going to take a lot more pressure from the ventricles to open that up, and then your end systolic volume is going to be greater, because you've got more blood left. So the more pressure you have, the more afterload you have, the greater your end systolic volume is going to be. The more blood you're going to have left in the ventricle because it didn't get pushed out because there's too much resistance. Okay, all good with that? So we've got all of these factors then are affecting the end systolic volume. And in addition to that, we have the stretch that affects the end systolic volume as well, the preload of the ventricles. Because the more, when you have a stretch on the ventricular wall, you're going to get a greater contraction, right? So preload is going to affect the end systolic volume. So the more stretch that you have, the stronger the contraction is going to be, the more blood that's going to get pushed out, and the less blood that's going to be left, which is your end systolic volume. So when we look at end systolic volume then, if you have an increased end systolic volume, if you have more blood left in your ventricles, then you're going to have less blood that got pushed out. So your stroke volume will be less. If you have less end systolic volume, that means you pushed a lot of that blood out that was in there, and your stroke volume will be more, will be increased. Okay. The average cardiac output is around 6 liters per minute, just like in that example that I showed you. Trained athletes at their maximum levels can have a cardiac output of 40 liters per minute. That's around 700% increase. If you're just exercising moderately, your cardiac output will go up to about 18 to 30 liters per minute, which is about 300 to 500% increase from rest. Okay, then we're going to finish here by talking about heart rate. And factors that affect heart rate. So let's look at factors that increase heart rate. First of all, the sympathetic nervous system. Sympathetic nervous system is going to increase the stimulation on the SA node and raise it from where it's normally at rest. And it also increases contractility, so you're going to get an increase in the strength of contractions. So you get a faster heart rate, and you get stronger contractions. Okay? But we're talking about factors that increase heart rate. So we have increased SA node stimulation from the sympathetic nervous system, which increases the heart rate. There's also a center in the medulla oblongata called the cardioacceleratory center. When this center gets stimulated, it's going to stimulate the sympathetic nervous system, and then your heart rate increases. Okay. And out in your peripheral blood vessels, you have these receptors, both baroreceptors and chemoreceptors. And chemoreceptors are detecting blood pressure, a decrease in blood pressure. Chemoreceptors are detecting an increase in carbon dioxide in either case. So if your blood pressure drops, or if your CO2 levels, carbon dioxide levels go up, you're going to want to get that blood back to your lungs faster so you can breathe that carbon dioxide out. You don't want carbon dioxide building up in your body. So you want to get it out as fast. You want to pump it to the lungs faster so you can breathe it out. And if your blood pressure drops, your body's going to want to get your blood pressure back up. And the fastest way to get your blood pressure back up is to increase your heart rate. So these two things, a decrease in blood pressure or an increase in carbon dioxide, will stimulate those receptors, baroreceptors and chemoreceptors. They stimulate the cardioacceleratory center, and the cardioacceleratory center stimulates the sympathetic nervous system, and then your heart rate goes up. Okay. We also have what's called autonomic tone. And in autonomic tone, the sympathetic nervous system is releasing norepinephrine at a steady background level. And norepinephrine will cause the depolarization to increase. It'll make the SA node depolarize faster, and that will increase your heart rate. Now let's go over and look at factors that decrease the heart rate. We have the parasympathetic nervous system. So the parasympathetic nervous system is going to do the exact same thing. It's going to do the exact opposite thing as the sympathetic nervous system. It's going to decrease the SA and AV node stimulation. So that right there is going to decrease your heart rate. And it also decreases contractility, but we're talking about heart rate. In the medulla, there is a cardioinhibitory center. And the cardioinhibitory center, when that gets stimulated, that will stimulate the parasympathetic nervous system, and then your heart rate's going to go down. Those receptors out in your peripheral blood vessels, they also are going to detect when blood pressure goes up and when carbon dioxide levels go down. So if your blood pressure is getting too high, or you don't have enough carbon dioxide in your body, we're going to want to decrease that blood pressure, right? We're going to want to decrease the blood pressure. So these receptors will stimulate the cardioinhibitory center. The cardioinhibitory center will then stimulate the parasympathetic nervous system, and then your heart rate will decrease, and by decreasing your heart rate, you will decrease your blood pressure. Okay, and by decreasing the heart rate, you're decreasing the flow of blood back to the lungs. Now less carbon dioxide will be leaving, and your carbon dioxide levels will then go up. All right, so there's also an autonomic tone with the parasympathetic nervous system. So the parasympathetic nervous system is releasing acetylcholine at a steady background level. And acetylcholine is going to cause it causes a slowing of the spontaneous depolarization. Acetylcholine is going to open the potassium channels on the SA node. So potassium channels are leaving. It's going to slow down that spontaneous depolarization. It's going to be harder to get to threshold. We know that the parasympathetic tone is greater than the sympathetic tone in the cardiac, at the SA node. So that's what we said, that at the SA node, it's normally 60 to 100 action potentials per minute. But because of this autonomic tone, because of this parasympathetic nervous system background tone, it's going to be at the lower end of that, and usually somewhere around 70, 72. All right, so now the rest of what we're going to look at is really just looking at factors that increase the heart rate. We're going to look at venous return, hormones, and then I'll just briefly mention sympathetic activation. So venous return. Remember, venous return is the amount of blood coming back through those veins and entering the heart. So if we have an increased venous return, more blood is coming back into the atria. It's stretching the atrial walls. The walls of the atria get stretched because blood is filling up. It's also stretching the SA node. That stimulates the SA node, and the SA node is going to depolarize more rapidly. Okay? A stretch of the SA node, we call that the Bainbridge stretch reflex. So when the walls of the atria are stretching, they stimulate that SA node. That's going to trigger the sympathetic nervous system, and you're going to get an increased heart rate. That's called the Bainbridge stretch reflex. The SA node gets stretched, so it gets stimulated. It's going to send out more action potentials per minute. There's other hormones too that I had mentioned on the other page. Epinephrine, norepinephrine, thyroid hormone, glucagon. They all stimulate the SA node, so they can increase heart rate. Glucagon used to be a drug that we gave to increase the heart rate. Right. And it also, epinephrine also increases contractility. So when a person is going into shock and their blood pressure is dropping, we want their blood pressure to go back up, we want their heart rate to go back up, epinephrine will be used. Anything that increases heart rate is called positive chronotropic. So when we were talking about stroke volume, we said ionotropic, because that's ions, sodium entering, depolarizing, strength of contraction. Anything that increases the heart rate is called positive chronotropic. So chrono means time. Chronotropic, speed. Positive chronotropic is an increase in heart rate. Anything that decreases heart rate then is negative chronotropic. If you have a massive sympathetic activation, so if there's a crisis situation, hemorrhaging, something like that, where it's just there's a crisis going on, your adrenal medulla gets stimulated, and the adrenal medulla puts out norepinephrine and epinephrine, right? And if there's too much being put out, if the myocardium become too excitable, then you can actually start to get abnormal contractions occurring in the heart. Okay, any questions? So when you come back, I'm going to have some case studies for you to work on. I'm going to also talk about Chapter 21, which has a lot of physiology in it as well. But then I'm going to have some case studies for you guys to work on, so you can kind of put yourself to work thinking about these things. Okay?